Hey guys, it's Dr. Keen, and we're going to move on to the next part of this slideshow. I told you chapter 9 is really long, so I'm going to give it to you in kind of segments here. We've already talked about atrial and sinus rhythms, and we're going to look at junctional rhythms and ventricular rhythms. Now, as I go through this, I'm going to kind of go fairly quick because you can look at this on your own too, but I'm just going to kind of hit the high notes as we look at this. But here's some vocabulary that you need to know: retrograde, premature junctional complex, junctional escape beats, junctional escape rhythms. We're going to look at what those look like here in a second. But remember, junctional rhythms are occurring right in the AV node area, so near like the bundle of His. The electrical impulse of the heartbeat is starting from that point. So you're not going to see a whole lot of a P wave on these because, or you're going to see an abnormal P wave of some sort, because remember, the P wave is representing atrial defibrillation or depolarization. So if there is no atrial depolarization or it's minimal, then your P wave is going to be either abnormal or it's not going to be there at all. So this is a little more vocabulary on the junctional rhythms here. Accelerated junctional rhythm. With a junctional rhythm, anywhere from a rate that's 60 to 100 beats per minute, that's considered higher than normal for a junctional rhythm. So that would be considered accelerated junctional rhythm. And junctional tachycardia, remember tachycardia is fast, so that is over 100 beats, just like normal. Just remember, like I was mentioning, this impulse is occurring right around the AV junction. So it's the SA node is too slow, or it's blocked, or it's not happening at all. So that's why the P wave is going to be different in the junctional rhythm. So that's what kind of gives the junctional rhythm away. Premature junctional complex here. So see, this is a normal complex here. You got P, QRS, T, but then there's no P here, and then another QRS and T. So the P wave is absent in these premature beats, but this is normal, normal again, normal again, normal again, but then you don't have that P wave again. So this is kind of like a intermittent junctional rhythm. Same thing here. So that's how you see that. The junctional escape rhythm is when the P wave actually goes inverted. It goes upside down. So you can see that here. So, and again, like I said, I'm going to kind of go through some of these fairly quickly because you can look at these yourself and review them. I've also given you flashcards in the Canvas module there. So I would suggest that you print those off and start flipping through them and reminding yourself of what these look like, and try and name them off yourself. But just some things to remember about junctional rhythm for the patient. It can cause fatigue, lack of stamina that can be caused from the medications that they're taking. They could have lung condition, lots of different things that can happen. But just remember that as a EKG tech, it is not within your scope of practice, which means it's not allowed for you to actually diagnose these EKGs or give suggestions to the patient or anything like that. That is what that's the physician's or the provider's job. So it's really just your purpose to set them up correctly, do the EKG properly so you can get a good reading, and then if you see something that may be a little bit off or abnormal, then you tell the doctor or the provider that, not the patient. You don't mention it to the patient. Just remember that. That's something important to remember about EKG technician. Here's some practice for the junctional rhythms. I'll let you go through these yourself. If you want to practice through the PowerPoint, I would suggest that you put it in like a slideshow format like this, so that you can see the EKG itself, and then kind of try and quiz yourself and try to guess what it is. And these are all showing you what they are. So you can see how the P wave is absent in most of these. See, this is a T wave, so not really anything here. QRS T, nothing. QRS T. Same thing down here at the bottom. You actually don't really even have much of a T wave, and so that's what gives that junctional rhythm away. Um, so even some more practice here. You got all kinds of practice here to look through these and try and quiz yourself. And like I said, I also gave you those flashcards, so make sure that you start going through and looking at those as well. Um, excuse me. Ventricular rhythms are the other part that we're going to talk about today. And again, I'm just going to go through some things with you, some high points and some things to remember about ventricular rhythms, but you really need to go through yourself and review it as well. You also have those flashcards for these. So those practices that I've been giving you, we're going to continue to do those too. So make sure that you're taking those seriously and focusing on those so you can understand and be able to identify these different rhythms. So premature ventricular complexes or contractions, those are some that you see in a ventricular rhythm. Now with a ventricular rhythm, different from the junctional rhythm, this is where the impulse is actually starting in the ventricle. So you're going to get a totally different wave from this. Remember, ventricular depolarization is signified by the QRS wave, so it's going to affect the QRS wave. And your P wave is going to be abnormal or absent there too. So this is just some vocabulary for you to remember. Bizarre should be pretty straightforward for you. It just means something abnormal. Bigemini and trigemini. These are when you see premature ventricular contractions every other beat, that's bigemini. Trigemini is every third beat. So that should be straightforward. Bi and tri, you should know what those mean. Unifocal and multifocal, that should be straightforward as well. You know what uni means one, multi means many. Focal means like a point or a location. So this is where it happens in one place. It happens in a lot of different places. Ventricular escape beats, it's kind of like the junctional escape beats. It's the SA node and other pacemakers above the bundle branches fail to initiate an impulse, so that's going to change the way that rhythm will show up on the paper too. Idioventricular rhythm. This one is a dangerous ventricular beat. It's also known as ventricular escape rhythm or agonal rhythm. Well, it's related to agonal rhythm. So it's a really low heart rate, and you get 3 or more ventricular escape beats. So it's potentially lethal. So this one's pretty dangerous. The agonal rhythm is when it's the same kind of beat, but the pace of the beat gets down below 20 beats per minute. So that's where it becomes even more lethal. So that one definitely needs to be identified. We'll look at that in a second. So and then these are similar to the junctional. Accelerated is faster than normal. Ventricular tachycardia is over 100 beats. So polymorphic torsatus de pointis. This is it's a variation of the polymorphic ventricular tachycardia, and the QRS complex seems like it's kind of twisted from one side of the electrical line to the other, and I'll show you what that looks like in a second. It's basically just like a bunch of squiggles is what it looks like. But and then you got bundle branch block. Bundle branch block is when the impulse through the bundle branches is being stopped, and so it causes the ventricles to depolarize one after another rather than at the same time, and it depends on which side, left or right, that it's happening. That will change kind of what that EKG looks like. But left and right usually impulse together. This is when actually one side impulse is separate from the other. So we'll look at that, what that looks like too. Ventricular fibrillation. Remember, fibrillation is very fast rate. It's like basically like a squiggle also, but it's a different kind of squiggle than this torsatus de pointis that we just talked about. So RNT phenomenon, we'll look at what that looks like. Asystole, that's a rhythm of basically no contraction at all, and also called a flat line. So some of you guys on your on one of the assignments that we did, you said flat line means that the person's dead. Well, that can be true, but there's other things that can cause that too, so we'll look at that. just remember ventricular rhythm. They originate in the ventricles. They have a real distinct QRS complex, and it shows up there because that's where ventricular depolarization shows, is in the QRS. And these are generally the most dangerous dysrhythmias, and you could see that as we went through the different types of rhythms that you would see. You could see how there was a lot of dangerous ones, a lot of lethal ones, possibly fatal ones. So premature ventricular complexes. Here's the QRS. You can see how it's real wide, and every beat is early and wide. So remember, a QRS wave should be what they call high and tight. It's basically like real fast. That Q to the R is very short, and then the R to the S is very short. So the QRS complex that is wide like that, that's a good indication of ventricular rhythm. Here's a unifocal and multifocal PVC. Remember, PVC means premature ventricular complex or contraction. The PVC is going to be inverted like that. So you got an inverted QRS. Ventricular escape beats. Again, these are ones that you need to go back and look through yourself and make sure that you're understanding and being able to recognize them. That program that I gave you online is really good for you to do that too, to go through and remind yourself what they look like. The flashcards are helpful. Going through these on the slideshow format so you can see what you should be looking for. But again, just like I said with the junctional rhythm and your scope of practice as an EKG technician, it is not your scope of practice. It is not your responsibility to diagnose or treat or interpret the EKG. You should be able to see that there's an abnormality and report that to the provider. But again, you're not going to tell the patient, hey, I see this, and you should be worried about your reading, because that is not in your scope of practice. Here's the bundle branch blocks. This is the right one. This is the left one. See how the left one is inverted. The right one is up and down. The T wave is inverted though. So ventricular tachycardia, again, that's fast. You can see how the QRS waves are wide. So you see a wide QRS wave, that's a good sign that it's a ventricular rhythm. Torsados de pointes, I told you it looks like a bunch of squiggles. So there it is. It's a bunch of squiggles. It's said in the description that it's the QRS are kind of twisting on each other. So here's a QRS going up and a QRS going down. Up, down, up, down, up, down, twisting. Ventricular fibrillation. So fibrillation is just it's a really fast rhythm, and there's basically no chance for it to create a normal rhythm, and so that's a good sign that they're in VFib. As you hear it referred to as that a lot. This is what you're using the defibrillator for, the AED or the paddles. This is what you're using that for, to get them out of that, because remember, those things stop the heart so it can reset itself. So here's that R on T phenomenon that we saw in the description. Here's the Q R S T. So you see how the R comes down to the S and then right into the T. That's an R T phenomenon. Here's the asystole. Remember, asystole, it can mean that they don't have a heartbeat, but it can also mean you need to check the electrodes and the leads. Hey, if the person's laying there talking to you, then you know it's not because their heart's not beating. You know that those electrodes and lead wires and everything aren't set up right. So there's a lot of different things that can change the way the rhythm comes out. So those are all things that you should look at. So make sure that you go through these and remind yourself of what you're looking for in the ventricular rhythms, and quiz yourself. Go through these and quiz yourself, and we'll go through some more rhythms in the next session and finish off this presentation.